Are you sick and tired of the high costs and inefficiency plaguing our U.S. healthcare system? Do you feel like you're navigating a maze when dealing with insurance companies, only to end up paying a fortune for basic medical services? Then this Broken Healthcare podcast is for you. So get ready to take control of your healthcare. Here's your host, Ray Kober.
Ladies and gentlemen, welcome to Broken Healthcare. My name is Ray Kober. I am your host, and I am joined today in studio, ladies and gentlemen. In studio, I have the Diathrive team.
All right. Thank you, Ray.
Chris Tucker and David
Flakus.
Thank you very much. Thanks for being here, guys. Excited to have you.
Pleasure,
Thanks for having us.
So how'd you get into this racket?
Well, I had the pleasure of knowing our CEO, Michael Hennessy, prior to this company. We'd actually become friends and worked together back when he was in the home healthcare supplying diabetes supplies, and I was managing a home care branch down in Florida. And fast friends, we worked together, and then he shifted his focus. He got the Medicare bid for supplies in the Southeast, and then ended up moving away, which I was not aware. And then company got bought third time, I want to say, and by the third buyout, I was ready to be done with home health care. The fun times were over, more or less. And
that's a tough racket. You're dealing with a lot of challenges there, no?
Several challenges. Managing a team, which is a lot of fun, but also presents, you're dealing with nurses, physical therapists, occupational therapists, CNAs, home health aides.
Yeah.
And then internal staff. Very dynamic, very fun, but definitely by the third go-around of changes, I was ready to transition. And my wife, who actually was in the digital health space, was doing very well, and I wanted to be her. So here I am. I made the transition over, and I love it. Diathrive is a fantastic product, and I love selling it. So
not many people would admit to wanting to be their wives.
That's good.
My man is in love.
That's right.
There you go.
That's true.
It's fantastic.
That's good stuff. And how about you, buddy? What brought you into this mess?
Yeah, so I'm on my second career, I guess. So I did the first 8 years of my career completely outside of healthcare. So I was in the Army for 8 years as an armor and cavalry officer.
Thank you for your service.
Yeah, I appreciate that. And then made the weird jump into healthcare. I don't really know still to this day how that happened, but did. Somehow landed at United after my service, and then spent about 10 years at United and Optum in probably 6 different roles there. So
UnitedHealthcare out of Minneapolis.
Yeah,
the evil empire.
Yeah, in the middle of the juggernaut. So I got but no better place to learn about healthcare and all the different cracks and crevices and everything that goes on in the industry. And then I got to know Michael and was able to find an off ramp and join a smaller company that I felt like was doing a lot of good. And it's been great so far in the last 3 years.
Okay, and so Michael who?
Michael Hennessy, who's our CEO and co-founder.
Ah, okay. So he came up with the idea for Diathrive.
Yeah.
And unpack your time at UnitedHealthcare with us for a little bit. And I'm not here to demonize or villainize the bukas, as we affectionately call them in our circles. And there's no organization that's all bad, for sure. What was your experience like there?
Yeah, I mean, to some degree, I think those organizations get a bad rap, right? The people there are amazing, right? There's amazing talent in those organizations, right? But they're built around making profit, and they're very good at doing that, right? It's a bureaucratic engine, right? But the U.S. healthcare system is based on bureaucracy, and if you don't understand it, you can't figure out how to actually affect change. And so the best place to understand the U.S. healthcare system is inside the bureaucracy that controls the U.S. healthcare system, in my opinion. And so again, incredibly talented people there, and everybody feels like they're doing the right thing. But if you take a step back and you start to look at it overall, what's the macro effect of all of this? Do I think things could be done better? For sure, right? I was fortunate to have several different roles there. So I started out in the Medicare Advantage space. So I saw how Medicare Advantage was built from the product side of the house, marketed that full-scale operation there. On the Optum side of the house, I was in the Optum Consulting Services or Optum Advisory Services. And so rebuilding sort of the exchanges, both in DC, Boston, Vermont.
Oh, wow.
And figuring out how all that stuff works. Also looking at the limits of government as they put things in place when the exchanges all crashed right after going live. That was super fun, right? To have a team of essentially consultants deployed from a lot of different companies to land there and try to unwind what was true mess. Lots of people have written about it, so I don't need to go into a ton of detail there. But
So wait, Chris, does this make you like a techie? I didn't realize that you're talking about interfacing and integrating the exchanges. And I don't know if folks, if you remember, but that was a complete shit show back in the day, right? When they went live.
nothing worked. Nothing worked. It was a complete shit show. I'm a non-technical technical leader in a lot of ways. It just somehow that ended up being my role in life, was just being able to sort through that mess and figure out a way around it. But yeah, it was a complete shit show, to your point, right? Everything about it nothing worked right. None of the connections to the carriers worked. None of the call center connections worked. Nothing worked, right? So just putting that whole thing back together was incredibly educational, because you got to see literally every part of the system, because you had to rebuild every part of the system, right? There was no part of that system that was salvageable, right? Basically, the entire thing had to be rebuilt from scratch in like 60 days, right, to get it working. At one point, we were running, the Vermont Health Exchange on a spreadsheet, really. It was a very big spreadsheet, but a spreadsheet nonetheless.
There's about 10 people in Vermont. It couldn't have been a very big spreadsheet.
It's a little more complicated, but yeah, I'm with you. So that was a really, kind of interesting experience, is getting to figure all that out. And then my last role was really working on the Optum Serve side of the house, which was really all the federal contracting side of the house. So working on VA-CCN, which is essentially a large TPA for the VA, and figuring out how that works and the rules and what are the opportunities and cost savings and better opportunities for veterans to seek care, which is still needed in this country. It was a good idea.
Right.
Implementation went decently well for any large government program.
Yeah.
Still some improvements obviously to be made on that side of the house, but really obviously a good experience. And then, like I said, gotten to meet Michael, and it was the right time for an off-ramp. It was the right time to figure, like, how do we build an enterprise solution? So at the time, Diathrive was really direct to consumer still. And we still have 35,000 direct to consumer clients that are out there that buy diabetes testing supplies from us, because if they have a high deductible health plan, they're essentially functionally uninsured, right? And so they still need to find a better place where they can buy affordable quality stuff. And then that's how we got moved into the enterprise space. And that's when I joined Diathrive, just build that whole enterprise stack up.
All right, so back up with me for a second. So for our audience, Diathrive, it's a service company for folks who are managing diabetes. Let's just unpack diabetes for a minute.
Yeah.
What does diabetes look like in the U.S.? How many people are affected by it? And is there a significant percentage higher rate of diabetes in the U.S. as compared to other parts of the world?
Yeah, it's way higher in the U.S. than compared to other parts of the world. So if you look at diabetes as a percentage of the population, right? So in a commercial population, so we always talk about two different population centers, really: commercial population, Medicare population. So diabetes is heavily correlated with age. So if you get over 65, you start to see a much higher prevalence of diabetes. But over the last 15 years or so, we've seen the prevalence in a commercial population go from like 4% to right now it's hovering around 10 to 11% within a commercial population. So it's just crushing health plans. It's crushing people's health, right? Type 2 diabetes predominant there's genetics that account for a big chunk of it, right? But a lot of lifestyle stuff, a lot of it just comes to our food, quality of ingredients, life sitting in chairs all day, driving trucks all day, things like that are more sedentary really drove that. So if you look at what the U.S. economy has done and people's lifestyle and people's jobs and things like that, it's not really a wonder why diabetes has spiked the way it has. Right. But the other thing is, and just to keep going on that path, right? So type 1 is something where you're diagnosed usually as a child, 8 to 13 years old.
They call that juvenile diabetes.
Juvenile diabetes. And then you'll live with type 1 diabetes really the rest of your life, right? So type 1, there's no control. That has nothing to do with lifestyle choices. That's just purely genetics, right?
Your body is not manufacturing insulin.
Correct. Exactly. Yeah. From that standpoint, and you have probably 1% of the population overall that's affected by type 1 diabetes, right? And then you can have other different types. So gestational diabetes, there's diabetes that can be caused from essentially if you go through cancer treatment and things like that, you can develop diabetes, right? So it's not all lifestyle, right? And a lot of times type 2 gets a bad rap where people just say, hey, it's because you're not doing the right things, you're not eating right, you're not exercising, you're not sleeping right. But when you really start to unpack that, like, it's not just that, right? There's a huge part that's genetics. And then beyond that, we're not giving people the opportunity to do the right things, right? Nobody's choosing to live with type 2 diabetes. It's happening based on circumstance in a lot of ways.
Yeah. So a lot has been made about what's going on. We're recording this now just before Thanksgiving. 2024. The election results are in. Trump is our president. This is not a political show. I don't care if you're left or right. I, for one, have been pretty vocal about my excitement and enthusiasm about Trump's appointment of RFK Jr. And many of the other appointments I just think are, again, whether you're right or left, and I know that there's such division going on right now in our country. I just wish we'd get back to common sense. Right person for the right job. Let's cut all the other bullshit out of the conversation. I'm super excited because I believe that our food supply and stuff that RFK Jr. has talked about, and I don't know if you caught the Senate committee hearing with Senator Ron Johnson when he brought in RFK Jr. He brought in RFK Jr., Dr. Marty McCary, Casey and Callie Means, and their brother and sister duo, right? She's a doctor who had her training in Stanford. He's a guy who worked as a lobbyist for pharma in D.C., talk about a power couple.
Right.
Yeah.
And she wrote a book called Good Energy. And the whole premise of the book is we have a food supply that has over 10,000 approved substances and ingredients here in the U.S. Less than 400 of those substances and ingredients are approved in the food supply of Europe and many other nations around the world.
Yeah.
And essentially our food supply is poisoning us, and it's contributing to diseases like diabetes. So I'm just interested in hearing your thoughts. Again, we're not a political show, but this is really just us shooting the shit, and the audience is a fly on the wall. So what do you say?
Well, I'm excited about getting a handle on our food supply and addressing it. I feel like RFK is definitely speaks the way a lot of people feel. Very matter of fact. I think he's out to make us healthier again. I believe him. And I feel like probably the naysayers are afraid because they're in whoever's pockets. But I think it's time. Like it definitely, we were talking before, we've known what to do since the 70s, right? With diabetes, it's not a new thing. But for some reason, diabetes is increasing. And I think that has a lot to do with how our food is manufactured. And I'm excited to see the impact that RFK can make on that.
And I think just the focus on food in general is good, right? I think when you start to look around, if you really start to think about it and you break it down, right? All of these additives came from the fact that we were trying to actually create more food, right? So that really hunger was a huge issue 50, 70, 80 years ago, right? And so all of this stems from like a decent place, right? And then it, like most things, got taken over by large corporations and got amalgamated into a profit generating machine, right? So how do you create the most food for the least amount of money, right? Which is what any organization is going to do. Any for-profit organization is going to do. That's what they're meant to do in a capitalist society, right? So it came from a decent place, but the problem is that we've gotten out of whack, right? The pendulum swung too far. And so to your point, like a lot of the food out there really isn't food anymore, right? At least not in a way the body recognizes food. And if you go to places out in central part of the states, right? You go to places in Ohio, you go to some other folks, there really are true food deserts, right? In a lot of ways, I'm on the coast, I'm in New Hampshire, you're in New York, right? David's in Florida. It's hard for us to appreciate it on a day in and day out basis, right? We have access to fresh vegetables, things like that.
Yeah.
But you go to a couple of these places, we've been out, like Bryce and Casey with IEN are out in Ashtabula area, right? If you go outside of there, maybe 10 minutes, like you're not finding fresh fruits and vegetables. You're not, like every restaurant is fast food.
Yeah.
Every restaurant is fried, right?
Yeah.
You go to parts of those things where it's just your best option for lunch is a truck stop, right? And it's just, I mean, really. And so it's like, okay, well, no wonder, right? Like, of course that's an issue, right? And of course you have to have preservatives to feed people at a truck stop, because it's not like you've got a huge bevy of coolers in there and fresh produce being delivered on a daily basis to try to help people stay healthy, right?
Right.
And so I think in a lot of ways, what you have to do is realize that is an issue,
right?
Accept it, and then start to come up with strategies to fix it. And on an individual basis, it's about figuring out how do you teach people to eat as healthy as they can when that's what's available to them.
Right.
Right? Like the gas station pizza may not be the best option. Not saying that protein bars are the be all end all, but maybe you grab that until you get to a spot that's got something with a better sustenance availability, if you will.
Right. Yeah, no, I couldn't agree with you more. And the funny thing is, though, it's not only the truck stop food, right? I think that's probably the smoking gun if we look at it. All of the ultra processed foods with all of the crap that's just super, super processed, that's literally engineered to addict you to it.
Yeah.
Right.
And have you eat more of it. And so it's just common sense. Like that shit's got to go.
Yeah.
But even if you try to eat healthy, are you eating product? Because we're not only you are what you eat, right?
Sure.
You not only are what you eat, you are what you eats, right?
Yeah.
Yeah.
Very true.
So if you think about that, when they talk about in her book, Good Energy, KC means, and I've read many books where nutritionists espouse, hey, we need to be eating organic as often as we possibly can.
Right.
You don't want, and if you go to the grocery store, even if you go to BJ's or Costco and you look at organic chicken versus non-organic chicken, it's like this shit is like Arnold Schwarzenegger chicken, so
true.
much bigger. And you have to ask yourself, is this good for me? And let's face it, I think even if you're eating chicken that is not organic, if you're eating it at home and you're not drowning it and drenching it in sauces and crap, you're going to be far better off than if you're eating just like batter covered wings and fish sticks and
Well, I just want to speak to that
aisles.
real quick because we are an organic as much as we can family.
All right.
And we were laughing at one of the hurricanes that came through. And of course, everybody makes a run on the supermarkets and we're late to the game because we're busy, whatever. But we never have to worry because we eat the organic stuff and nobody ever with the organic stuff on the shelf. So it's like fully stocked organic section.
No one's rushing.
Even when they're like worried about a hurricane, it's like, I'm not eating organic
Yeah,
stuff. So it's
yeah,
like,
right.
no, but it's so to that point, like we're not eating enough organic and it's not even the communications amiss there as well. I think there's an opportunity for that. We communicate that. So.
Well, and to some degree, that should just be more the norm, right? Like, we
Right.
really shouldn't have to have necessarily an organic and a non-organic food section, right? At the end of the day, I think it's just about making all the food, to your point,
Right.
bringing it up to that standard.
Yeah.
Yeah, no, I don't think the steroid-induced chicken is probably great for us in the long term.
Definitely.
So it's like,
I know.
we could get back to normal chickens. That
Yeah.
probably would work well for
Might
us.
make sense.
Yeah.
If we could have the perimeter of the supermarket start to encroach on the midsection, because they always say shop the perimeter.
Yeah.
That's where the fruits and the vegetables and all that stuff are. And I'm also excited I know that we're going to see an updated food pyramid. I'm quite sure that we're going to see a long overdue updated food pyramid. And I'm also excited about what it means for our kids, for school lunch programs and stuff like that. I mean, just think about it. And why would anybody be against this?
Yeah.
Again, whether you're right or left, and even if you're Robert Kraft, and I'm a Jets fan, so I don't like the Krafts, but you know what?
That's worked out well for you in the last couple of years, right?
Thank you,
Good
buddy.
call.
Let's not talk about that.
Right.
But I do admire Mr. Kraft because I do think that from what I know of him and hearing him speak, and I believe they actually, if I'm not mistaken, they might have changed their Kraft macaroni and cheese ingredients to take out the yellow 5, and they were lobbied to do so. And I do believe they acquiesced and did it. Yeah. So I don't believe he's a bad guy. But if you're sitting at the top of the food chain, running an empire like Kraft Food, I think we need to get those folks on board and just say, you know what? If it means a hit to your bottom line that you're going to have to make a little less profit, but it's for the benefit of our children and our grandchildren, it's high time that you do that. And maybe it means making the cost of the product a little more. And I wish it wasn't about that. And I guess that's going to be the counter argument. Like, oh, if we do all of this, how are we going to feed the masses?
Right.
I think we could figure that shit out.
I feel like what's the cost in the long run on the health? So what's the balance? And it does have to be an all-in. Everybody has to come to, and I'm hoping that's an RFK thing too. It's like bring the big dogs together, big macaroni and cheese, whatever it is, and have them all buy in and understand it's a movement. Everybody understands that RFK was a part of the platform, right?
Yeah.
And Make America Healthy Again was a part of that. And I feel like this is an opportunity. You seize the window because now would be the time. And I think could be huge.
Yeah. we choose to do this not because it's easy era, but because it is era hard. This is no different. I mean, his uncle put a man on the moon, the first man on the moon. I think if we did that, we got this. We could tackle it.
I mean, there's definitely things you could do, right? I mean, to some degree, when everybody complains about the cost of groceries right now, and the cost has gone crazy, right, with inflation and all the other things that are going on, and it is affecting across the board in their pocketbook. But the one thing you might take away from it is saying, okay, to some degree, if we get that to be the norm from a pricing standpoint, instead of really just focusing on the pricing coming down, if we just move the quality up to the price line, right, instead of in it, because I do feel like there's been a lot of profit taking in that spread, right? So if we can move the quality up, move the standards up, then I think we have moved to a higher cost of food already, right? If we just stay there but have a higher quality, we're probably in a much better shape long term. And then equate that back to health, right? I mean, start thinking about the fact that how are you going to afford healthcare long term? Healthcare, from an inflation standpoint, is way outpacing food, right? You think about like food, I don't know the stats off the top of my head, but let's just say food has moved up 10 to 15% over the last 3 years in terms of cost, right? Healthcare's moved up, what, 40% in that same time?
Yeah.
Easily.
Easy?
Easily. So you're a UnitedHealthcare guy. If you had the wisdom and the knowledge to invest $10,000 in UnitedHealthcare stock in the early 90s, you'd have a couple of $1 million today or thereabouts, pretty much, if you reinvested the dividends. I've done the math.
Yeah, sure.
It's insane. And so healthcare inflation comparatively is just enormous. And how to, just pull up any Kaiser Family Foundation report and look at the rate of wage increases, the rate of inflation, and the rate of healthcare inflation is like a hockey stick.
Yeah.
It's just insane.
Yeah.
So I was talking to my wife last night over dinner and told her you guys were coming in and told a little bit about what you did. And full disclosure, like, this is not a sales pitch, right? No. I believe in your plan because we've installed it. We've seen the benefits and we've seen how it works. And lots of folks, are going to be tuning in, not just, people in our circles, but your every average day people who might be managing, chronic diabetes, type 2 diabetes. So I'd like to hear from you, like, well, how does that work? And my mom, she feels like my mom sometimes. My wife is my worst critic. She's like, you can pry my United Healthcare card out of my cold, dead hands.
Gotcha. Yeah.
She's warmed up a lot since I've been doing this stuff. She's come a long, long way. But she's like, how is it? And I was like, well, off the top of my head, if you're getting your diabetes supplies through your company's health plan and it's going through your PBM, those motherfuckers are making money hand over fist.
Oh my gosh.
I'm sure that might have a little something to do with it. So speak to that. If someone who's a listener that's managing diabetes, what's in it for them? And then for employers, HR folks, CFOs that might be listening saying, well, hey, we're in a self-funded health plan. We're spending a few $1 million a year. Is this something that might be good for us? So if you could talk a little bit about that would be great.
Well, out of the gates, we're going to be a savings for the members because we eliminate copay and coinsurance. So their annual spend is decreased right there. Because we manufacture the glucometer and the test strips and the pin needles and the supplies, more or less, we're going to save the plan. We do the side-by-side comparison, and we're going to save thousands of dollars to the plan. So those are the savings that are the hard savings. And then, of course, whenever a member is managing their diabetes, there's going to be less trips to the ER, less hypo events, less need to go to the endocrinologist. So there's a soft savings for sure as well. And then part of our solution, because we do a free claims analysis that Tuck was the man to develop, we can determine who's living with diabetes on the plan, who's testing and who's not testing. So, of course, we address the folks that are testing, and that's who we enroll at first. But then we also will do a reach out to the people that are
Wait, we're close to Christmas, so that's like Santa Claus. Who's naughty and who's nice.
Exactly. Well,
Really
the people that aren't testing are the ones that are going to be the high claim, right? They're going to cost the plan the most because they're not taking care of themselves. So part of our solution is also to reach out to those folks to try to get them engaged as well.
Yeah, and a lot of the folks not testing comes in a lot of different flavors, right? If you've been living with diabetes for a long time and you're not testing your blood sugar, it can be because you can't afford to do it anymore. Like last couple of jobs you've had, to your point, you've been in a high deductible health plan. You go to the pharmacy, average cost strips, CVS right now for about a box of 100 test strips is about $114. So And if you have a $5,000 deductible, you're paying all of that all year. And that just starts to become untenable. And that's about a month's supply, right? A little bit more in a month, depending on how often you're testing your blood sugar. So you're spending $114 a month. Like at some point you start being like, yeah, whatever. Like I'm done, right? I just can't do it, right? Or you start making choices like, hey, my kid needs sneakers this month, so I'm not getting test strips. Or you start rationing your test strips, which we see all the time. Like, hey, I'm going to test once every other day. Make sure it's on top. I'm going to test once a week just to see, which essentially is not testing your blood sugar, right? Like functionally, that's not testing your blood sugar. So that's what, and so when you kind of
that's an important point. So I was pretty much raised by my mom single-handedly. My mom buried 2 husbands. So she married her childhood sweetheart, and he passed away. He came back from World War II, must have had some type of a congenital issue. He died at like 26 years old.
Wow.
She was lucky enough to find my dad a few years later. My dad was an oil burner mechanic, got married to him. I was an oops baby. She had my brother, Jimmy, my middle brother, and then me. I came like 10 years later. So there's 18 years between me and my oldest brother. And then my dad was diagnosed with lung cancer, and she buried a second husband. Ugh. And so I share this story because imagine being a single mom raising 3 boys, and you're a 1-income household, and healthcare costs what it costs.
Yeah.
How the fuck do you do it?
Yeah.
Right.
Insane.
How do you do it?
Yeah. We talk to people all the time. It's a great example, right? So type 1, I was telling you, a lot of times happens when you're, 5, 6, 7, 8, 10 years old, right? And you walk out of the doctor's office saying, hey, you parent, now you have no medical training whatsoever. You're in charge of keeping your kid alive. And hey, you're going to have to give them this shot many times a day based on their blood sugar range. Here, can you just memorize this? I got 15 minutes with you. Here, let me give you a card, send you out of the office, right? There's a great example. We got called by a client. This was about a month ago. This exact situation happened to them. And the next day, they were in the ER with their son because they didn't know if they give them too much insulin, too little insulin. They didn't remember what the numbers meant.
Well, people are so stressed. They're there. It's like their world is imploding, and they're supposed to not only listen, but retain, and then be able to do.
Yeah.
Right, exactly.
Within what, 20 minutes, 15, 20 minutes? Like,
within 15, 20 minutes of an appointment,
Yeah.
right? And so they were in the ER the next day, and they're just completely freaking out. And then they go to the pharmacy to try to get supplies, and I forget what the bill was exactly, but it was like $600-700 worth of stuff that they needed all at once. I think that was a huge hit to their budget at the time. I don't know them personally, right? But it was a big deal. And so all of a sudden they're like financially impacted. They're impacted on a day-to-day basis. They're freaking out. They're stressed out about the health of their child. They're all of a sudden a caregiver, full-time caregiver, right? So like everything to your point. And then if you were use your family situation as an example, if you're a single mother, you got 3 other kids, right? It's completely overwhelming in that regard. And from a financial standpoint, you're just getting crushed because you don't have the clinical support, right? If you call a primary care right now, depending on where you are in the country, you are lucky to get an appointment in 6 weeks. Like lucky. Like
6 months. In New York City.
Yeah.
The last time I checked.
Yeah.
Not to slam NYU. NYU's a good healthcare system. My doctor's affiliated with NYU. Tried to get an appointment. I called. Can't make this shit up. I called in August. First appointment was available in January.
Oh my gosh.
Give me a break.
Yeah.
Right.
We moved to New Hampshire this summer from Connecticut, and setting up appointments I have 3 boys, for our boys, primary care physicians. We've called 4 times. We haven't gotten a call back to just get the first appointment.
Unbelievable.
Right, set up. And we'll be lucky if that happens by the time they need school physicals for next year, right? Like there is a massive shortage. And then when you take it to the next step for diabetes and you need a specialist, because a lot of primary care physicians are sending you to the endocrinologist, especially if it's type 1 and it's pediatric and want to make sure 6 months.
Unbelievable.
Like 6 months to get into endocrinologist. And that's average across the US. So there are parts of the country that's a year out.
Yeah. And that's why I believe personally, the future of healthcare in the U.S. is centered around direct primary care, value-based primary care, where your doctor is not affiliated with the healthcare system. They're invested in you as their patient. You go to their office. It takes you, they'll see you same day, next day, or like worst case, 1 or 2 days out.
Yeah.
They're going to spend an hour with you when they're with you. You're not going to spend an hour or two in the waiting room for them to see you for 15 minutes and you get rushed out the door. They're going to take time with you. They're going to put hands and eyes on you. They're going to treat you, and then they're going to guide your care. And our system right now is just not set up to do that. Our physicians are just totally overwhelmed and overloaded.
Completely.
And that's got to change.
Yeah, completely. If you look at, it's just to your point about earlier, I started talking about bureaucracy, right? And how the system works. If you wanted to go set up a primary care practice today, right? You could have 1 doc, 1 nurse, and 3 insurance folks in your office.
Yep.
Minimum.
Yep.
Just to try to keep enough claims dollars coming in to keep the lights on.
Yep.
Right? And to deal with claims rejections and looking up claims codes and doing that. So, like, how do you get that set up, right? And so then the answer became, like, you have these giant systems. Well, now you have the giant systems, and everyone's paying for a network access fee. And again, nobody can squeeze enough people through there to make it work. So you have to go back, to your point, a simpler system. And I think direct primary care, I agree with you, is a huge key to unlocking the U.S. healthcare system. One of the things we do is actually we work directly with a lot of direct primary care clinics where folks that are looking or need that diabetes specific care get referred over to us within the clinic, right? And then we present all the medical notes back through their EHR so that it's a consistent experience. Because that's the other big thing, is that you really need a consistent experience. Everyone underplays the member experience. But we start talking about controlling costs, doing that through prior authorization, doing that through reject codes at the retail pharmacy is like the worst member experience you could possibly come up with. And like, oh, this is great.
You don't like going to CVS and standing at the counter for them to
for 20
dick
minutes?
you around for a half an hour?
You're at the wrong location.
Give you the retail price, right? Oh, here's your script. This will be
You're going to take that away from me?
$11,000.
Is that what you're saying?
Right? Yeah.
Jeez.
Unbelievable.
Yeah. So to your point, that DPC experience is much better, and therefore people will engage with the doc, and the doc has time to engage with the individual, and then all of a sudden you start to actually do healthcare, not transactional care, which is essentially what we've been doing.
This episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today. So what does good healthcare look like for a diabetes patient where their care is managed properly?
Yeah, so you can be super well controlled, right, as living with diabetes. So it's a little controversial to say diabetes can be cured, right? And I'm not a clinician, so I don't try to espouse that. But from the best readings we have from our clinical experts, best case scenario, you can put diabetes into like a remission-like state, right? You can get it under your A1C in super well controlled. And that's kind of, you have to meet people where they are to start with though, right? Because everybody's coming at this from a different point of view. You can be living with diabetes for 15 years and be fine, right? Essentially symptom-free and feel okay. But then something changes. You get older, your hormones change, maybe your diet changes, maybe something happens to you, maybe you have gone through a treatment, and all of a sudden you're completely out of whack from a blood sugar perspective. And then it's time to really buckle down because, and honestly, you really should have been managing the entire time, but now you're almost in a state of crisis, and it's how do you get back under control? The long and the short of it is that there are definitely things you can do. The first thing to do, though, is to be testing your blood sugar at least twice a day. If you're living with type 2 diabetes, testing your blood sugar twice a day. And again, some people think that's controversial, but at the very least, you know what your baseline is, and you know when it changes. So you have a better sense of saying, okay, I'm generally in range from 180 to 210, right? And that happens. And all of a sudden, if it changes to, hey, I'm getting like several readings in the 300 mark, something has changed. I don't know exactly what it is, but you need to figure that out quick before that becomes your new trend, right? And the only way you're going to know when that changes is if you've been testing all along.
And so how do you do it? I know that the technology has evolved, and I have a cousin that was he wasn't born with it, but he was in a car accident, and that triggered type 1 diabetes.
Yeah.
Yeah.
And so he's like a trooper. And I say anyone with diabetes, they're like badasses because you might say, oh, it's a little needle, but you try jabbing yourself multiple times a day,
Nobody
every
likes
day.
needles, come on.
That's got to be a complete drag. And I know that there's continuous glucose monitoring devices and stuff like that. How much does that play a role? Is there technology on the horizon where it's going to be less invasive than piercing the skin or a wearable like an iWatch? Will that come into play? How do people generally manage this, and where do you guys come in? I know that you said that you invented a monitor and you manufacture a monitor and that you provide supplies. What is the norm, and is there like a good, better, best way?
Yeah, so I think the norm is right now is still prick your finger, right? Unfortunately. But the most accurate way to measure blood sugar is through your blood, right? Continuous glucose monitors measure interstitial fluid. So it's like blood in terms of like it gives you more trending data, but it's not as accurate as measuring your blood sugar directly from your blood.
Oh,
right?
interesting.
So a lot of folks have been living with diabetes for a long time. They use the continuous glucose monitors to really know when they're trending up or trending down versus what the actual number says. So that number can be off a little bit. And different CGMs have different accuracy ratings. So that's the state of the industry right now. Your kind of traditional method where you prick your finger, measure it. There's various different degrees of accuracy. We went with a very high degree of accuracy in our test strips. Then there's your continuous glucose monitors. Then several things that are in, I'll call it, different stages of FDA approval right now. And there's a lot of innovation continuing to go on in this space. The tricky thing, right, is that CGMs for a lot of folks are unobtainable from a cost perspective. So if you look at the Freestyle Libre 2 and 3, they're anywhere from $150 to $210 a month. The Dexcom G6, G7, they're $350 to $410 a month, roughly speaking, right? And then you get into the whole rebate game. And there's rebates attached to all of them.
Right.
And so what's your real cost on that?
Yeah.
Well, it depends on who your PBM is, how big your group is, what your negotiating power is, what fees they attach to your rebates. So then you get into the shell game and having to worry through that. So
yeah, so I had Renzo Lozati on from USRXCare, CEO USRXCare. You know what he calls rebates?
what's that?
Fool's gold.
Yeah. It's a really great way of saying it. Yeah, I think Renzo's got a great point in that regard, right?
Yeah.
Like you can't count on a rebate dollar. Can't count on it to save your life. You look at GLP-1s right now. There's massive issues in terms of how people think about the rebate dollars on a GLP-1. So average list price on a formulary right now for Ozempic is anywhere from like $950 to $1,050, roughly speaking, right? The rebate on that drug is anywhere from $450 to $600, depending on who your PBM is. And again, you're not getting that entire rebate because most PBMs are taking anywhere from 10 to 70% of that rebate dollar.
Yeah.
Or you're not getting any of the rebate dollar, depending.
Right.
So that whole structure, to your point, is crazy. And then as a plan, if you try to put any restrictions on the use of those GLP-1s, any whatsoever,
Right.
the manufacturer will hold the rebate hostage. So you're not getting a rebate back at all.
Crazy.
So like, how do you bank on that? And oh, by the way, your rebates are coming 6 to 12 to 18 months down the line. So you're always, to your point, playing it forward.
Right.
In terms of trying to figure out like, well, what's my rebate going to be on this? So how do you budget for that if you're a CFO? And then so like benefits departments essentially just use that, not all. I don't want to paint all benefits departments in the same brush.
Right.
But that's their like slush fund.
Yeah.
Like, hey, I got $500,000 coming back. Maybe next quarter, we'll see what the actual check looks like.
Right.
And then we'll figure out what we're going to do with it.
Right.
Maybe that goes into the wellness fund. What it doesn't do is ever go back to the patient. Right?
Yeah.
It never filters back to the patient, ever.
And that's the problem, right?
And that's the problem.
And so if you look at it, and why does Renzo call it fool's gold? Because really, you're being lied to, right?
Sure.
When you're playing the rebate game, shouldn't it be a lot more cut and dry? Shouldn't it just be having a PBM that's hopefully a fiduciary PBM like a USRXCare that is going to source the drug and they're going to charge you a per fill fee? Would you prefer that, or do you want to play the game of a manufacturer creating a drug? You're dealing with one of the Buca RX PBMs. OptumRx is the largest profit center by far in UnitedHealthcare.
Sure.
So that should tell you a little something about what's going on. Are they profiteering off of these drugs or not? And clearly the answer is yes. So eliminate all that stuff. Cut out the middleman and go directly to the source. But I think one of the biggest problems with diabetes is people can't afford it. So they can't afford their share of it, which is also a big problem with many of the health plans out there, people that are married to their fully insured plan designs who just resist the whole concept that healthcare is a supply chain that can be managed just like anything else that you procure. And that thought process is surely costing plans billions of dollars in this country. Folks have to break away from that. When they implement a solution like yours, now their employees not only, and you correct me if I'm wrong, but it's more than just the supplies. There's also an educational component to it. And now people are taking their prescribed regimen, doing their blood tests regularly, and there's hard scientific data and evidence to support the fact that folks that are taking their medication as prescribed, that are monitoring their blood sugar regularly, they're doing better with disease management. Yes or yes?
Oh, yeah,
Absolutely.
100%.
Let me just jump in real quick. And I just want to speak to engagement real quick because I think that's so key to our solution. And across the board, I think most point solutions average around 5%, maybe up to 10. Ours is around 80%, if not higher. And that is key for the employer to know as well, because they're paying all this money for these point solutions or wasting time with these point solutions that nobody's using. They've been sold a bill of good on one thing or another. And not to say that it's a bill of goods, but it's a solution that fits such a small percentage of their population where we address all types of diabetes. And I think that's been key. We spoke a little bit about the pediatric juvenile situation with the 7-year-old, or all the way up to the type 1 person that's been living with forever. And then how key the health advisor plays into the filling that clinical chain. So one more thing I just want to definitely point out for an employer who might learn about us is that we are holistic. We address all forms. There's no, do you qualify? There's no form that you fill out. We do the free claims analysis. We can identify the folks that are living. Those are the folks that get enrolled right away. And so that's why our engagement is so high. So
this episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today. Thank you for sharing that. The truth is, if you break down the supply chain of healthcare, that's one piece of it. The other piece is people in the business of paying for healthcare need to know the numbers, right? So Warren Buffett famously said GM is a healthcare company with an auto unit attached, right? Because he studies the numbers. Where does that come from? He's looking at the balance sheet and the P&L, and he's like, oh my God, how much money are we spending on healthcare with GM? And so you need to understand how the numbers break down. And when folks bother to do their homework and their research, and they realize that 80% of your expenditure, 80 to 85% is claims. Well, if you want to lower the cost of healthcare, what do you have to do? You have to focus on claims. So what I love about your solution is, and maybe you could talk a little bit about the fact that you're validated by the Validation Institute. I always look at that because I think that it kind of separates the men from the boys in our business, where when you have a company that is willing to put their money where their mouth is and have the Validation Institute scrutinize your claim, if your claim holds up, that holds a lot of weight with me as a benefits advisor. But I'd like you to talk a little bit about that, and just when you look at the getting back to the claims question, it's not the small ticket stuff that's driving your costs up, folks, right? It's not the visit to your local doctor that's doing it. It's really more about being price gouged with RX, being price gouged when you go for a major diagnostic exam like an MRI or a CAT scan, and doing it in a health system for 10x the cost of doing it at a freestanding radiological clinic. It's about the complications of not managing a disease property like diabetes, and then the resulting inpatient stays, surgeries, et cetera, et cetera. And so I think that's why your solution is so effective. And what I love about it, and I tell people all the time, look, I love saving organizations millions of dollars on their health spend. But you know what I love even more? Being able to design a plan that delivers healthcare to people, the boots on the ground, everyday people like you and me, for free. And so I think what really resonates with me about your product is you really have a solution that says, hey, if you're managing this disease and you're stressed out about the expense, stress no more.
Right.
And for an employer, you're saying, here's a program where it's mathematically proven, and we have the study to back it up. For every dollar that you put into this, you're going to get a return on your investment. So maybe you could talk about the Validation Institute study a little bit and what it means for patients.
Yeah, I think Validation Institute to us is it's just the math, right? Like we looked at 500,000 claims across 3 years. We presented all of that data to the Validation Institute, and they were able to give us their highest level of validation. So for us, that was a no-brainer. To your point, it's that stamp of saying, hey, we did the hard work. We went through all this to show you what that is. But to your broader point, one of the things that I look at is if you look at high deductible health plans, right? Everyone thought these were going to be the next coming. And this whole like concept of you've got to have skin in the game. Skin in the game only works when healthcare consumers know how to shop, which they don't, because we don't make it easy to shop. So skin in the game is just like misnomer that's out there. Like everybody has to have skin in the game. Sure. So that they can price shop between.
I have an idea. Let's have a health plan that has a $20,000 out-of-pocket deductible. Right. First dollar of coverage comes after 20 grand. Right. And then if people really need health care, if they really need it, then they'll go. But otherwise,
you know how much money you could save, right?
Excuse me. I'm on antibiotics, folks. It's been a tough week. Otherwise, they're gaming us, right? But that's what they portended with these high deductible health plans. And we know from the studies, people don't have $400 saved for a rainy day.
Yeah.
And the average deductible is creeping on $2,000 a year.
Right.
Yeah.
Your people can't afford your health plan.
They can't afford it, and they can't do what you're telling them to do. Like, they can't shop it. Like, give a hospital a call right now and just be like, hey, I'd like to know what my cost is going to be for procedure Y. And then call the next hospital and ask the same question. First of all, you're not going to get an answer at either one of the hospitals.
No way.
And then you wouldn't be able to compare their answers once they came in because they would have all these different stipulations on them.
Yeah.
Well, if this happens and if that happens and if you see this doctor and that doctor and this. So, like, how exactly are we telling people to have skin in the game and shop for it when there's no effective way to shop for healthcare? Yeah. So, to your point, that's one of the reasons that we feel really strongly that the members shouldn't have any copay, any coinsurance on this, right? To some degree, that's a giant waste from a concept perspective for somebody that has a chronic disease.
Right.
They have to do this every day. Like every month they're going to need to get supplies.
Right.
Because we're asking them to test their blood sugar every day because that's the starting point upon which they can start to get healthier, get their blood sugar under control. So they need less healthcare services for the future. So asking them to pay for that is super counterproductive.
Yeah.
Right.
Yeah.
And so to your point, in the fully insured market, zero control. As a broker, right, like it as an advisor, you have no control about what that plan does in a fully insured, right? I mean, it just is what it is.
Zero.
And so if you're making a healthcare decision, right, why are you going to take someone else's word for it, right? Like the worst kept secret in healthcare is that a fully insured plan from the payer perspective is managed way more tightly than a self-insured plan, right, by the same carrier. They're not even the same departments.
Right.
It's not the same care team. It's not the same claims team. Sometimes it's not even the same claims system. It's all about choice. It's all about making smart choices and having trusted advisors there that can walk you through this and not just parroting carrier lines like you got to have skin in the game and nonsense, right?
Yeah.
You got to, and then when you do that, to your point, you can get rid of people's healthcare spend, right? And have the plan costs 50% less than it costs a year over. So like you can do a much better job with some very basic concepts.
Yeah.
Right.
So give us an idea. If I'm listening to this and I'm head of HR for an organization that's managing, I don't know, 6,000 lives, maybe I'm spending somewhere in the ballpark of $70 million a year on healthcare. What do the numbers look like based on experience? What would you say that the average savings would be on a group like that? Now, that's a large group, right? I'm just wondering, like, if you're of the mind, and I'm thinking of an actual prospect that I have that is in that ballpark, and they're self-funded, but they're in an ASO arrangement with the insurance carrier, and they have very little in the way of cost containment solutions. What would the benefit be to an organization like that?
Yeah, so if 6,000 employees, let's say 10% of that population is living with diabetes, roughly speaking, this day and age, that's what we see. It's different depending on where you are in the country, right? You'd save roughly $1,500 per person living with diabetes. So you're in that $600,000 to $800,000 range right out of the gate.
Wow.
Before first dollar savings right out of the gate, just on supplies.
Yeah.
And then you start getting into what's year 2, year 3, year 4 savings in terms of better health outcomes, right? And so that's one of the reasons that we split our savings analysis into hard dollar cost savings and soft savings, right? Because it used to be those things just got like mushed together, and it would be like, hey, you're going to get this giant number. But the reality is, one, you're not saving healthcare outcomes for the most part, right?
Yeah.
There's an opportunity we could divert an ER visit or something like that for sure. But that's, you don't really bank on that necessarily. So it's about, okay, we're saving you money right out of the gate on the supplies because we cut out all the middlemen. So it's our stuff, it's a capitated plan. Boom, you start saving money. And then it's about saving money after that. So
Interesting. So, and how does it work? So if you're an advisor out there, a broker that wants to install this, is it a heavy lift? What's needed on your end for you to do the complementary analysis so that a group can see what the savings looks like?
yeah, you just did one of these in like 15 days.
Yeah, it's super simple. At the end of the day, the pharmacy claims data is what we would really need. Sometimes the medical claims helps as well, but sometimes pulling the claims data is not the simplest thing for the folks, so we try to make it as easy as possible. We usually can turn a claims analysis around in 48 hours.
Yeah.
And then come back, present side-by-side comparison. We can see the savings. And then a 30-day implementation plan right out of the gates. And we have a very comprehensive implementation program. We can be on or off cycle, so we can work around the needs of the employer or the client, however it works.
Interesting. And so the other thing is, I would imagine, based on what I'm hearing, first of all, I encourage everyone always to do their due diligence, right?
Yeah.
I think you have to measure twice, cut once, especially when you're dealing with something as sensitive as healthcare. I interviewed the CEO of Raven, Alaska, where we did install Diathrive. And Rob McKenney, the former CEO, said the scariest thing I did was put you guys in and take out Blue Cross Blue Shield, because you feel the weight of that as a leader, right? You're messing with people's lives. But he was courageous enough to take the leap because we spent time with him and we showed him the hard data, and we said, there's just no way your health plan is going to be worse than it was. It's going to be a better member experience for your people, not a worse member experience. You're going to save a ton of money, and we're going to deliver healthcare for free to your members. And naturally, be skeptical, ask questions. And I encourage our listeners always, this provider through its paces and see what you see.
Yeah.
But at the end of the day, I look at stuff like this, and I hate to use the term no brainer, but if you do the math and at the end of the analysis, you're clearly going to come out way ahead, then what the fuck are you hesitating about? Like, really?
Well, and I think you just spoke to it a little bit. There's the fear factor of taking the leap. People have their comfort zone, and I don't think we're a risk, but in their minds, it's like, well, do I want to take that leap? And I think more people are coming on board and understanding it's not that big of a jump. But there is that to some degree. Yeah.
So insurance carriers are not your friends, folks. I've said this before. And the reality is, if you can trim the fat and have their margin be your opportunity, then why the hell wouldn't you do that? And certainly, I think you have the clientele to back it up. And the other thing that comes to mind is I bet you don't lose clients very often. What's your persistency rate like?
98% right now. And we're just coming under just about 1,000 clients. So self-insured plans.
Yeah, that's a lot of clients.
Right, and I feel like part of it is that we're such a simple solution, right? And I think that, like I said, we've known what to do since the 70s. But our industry went down this AI path that's like this really shiny and cool thing. And I feel like the members got left out of like, hey, what's going to be easiest for them to work with rather than some cool bells and whistle stuff or this really particular diet that they have to adhere to. What is it that everybody can do? Very simple. We're there when you need. It's a behavior issue, right? So we really address the behavior side of it, the psychosocial side of it, which is key. And then health advisor that becomes part of the team. We share data. We're partners with their clinical team as it is. It's such a simple choice, and it's so easy for the members to embrace. I feel like that's another reason why we're taking off so strong. So,
and I think the other thing I would say to that is just that we have to realize that the country is not made up of folks living in Silicon Valley. Like, it's not made up of everybody that has the newest iPhone and an Apple Watch and every other sensor that they would want to have to try to optimize their sleep patterns and optimize their run. That's a portion of the country for sure. That's not the majority, right? So if you put in solutions that are only going to serve a very small minority of your workforce,
right?
Like, what are you doing? Like, you're just buying into the hype, right?
Yeah.
So to some degree, we're a meat and potato solution, right? But that's the majority of people that need us in a lot of ways. We still have several clients that don't have smartphones, right? Where our nurses are talking to them on flip phones, basically, right?
I want to be friends with them.
Right? It's just, when I first joined the company 3 years ago, there was an organization in Pennsylvania, middle of Pennsylvania, that sadly is no longer in business, but they actually had an office set up in their sort of main office area where members could come and make a call to our nurses when they wanted to talk to them about something, because there's no signal. And they may not have had their cell phone on them all day, and so it was a straight landline, right, connection. And so
they're off the grid.
They're off the grid. I tell these stories sometimes. People are like, no, that can't be true, and it's like, no, there are parts of the country where like that is very true, right? And so like technology-heavy solutions for sure have a place. Don't get me wrong. Like we need to continue to innovate, but you also have to realize that you have to crawl before you can walk, and you have to walk before you can run. So it's really about how do you address the majority of your population that's having a hard time, right? And how do you start getting them healthier?
Well, so a great thing that you said before, and I'm a very visual guy. Like I told you, I dreamed about being Steven Spielberg. That's why I'm doing this gig. I don't know how that's going to get me there, but
dare to dream, baby. You never know.
Whole other story. But I'm thinking to myself, how important it is in our business in general. What you said that really hit me is meet people where they are. And that's something that as a career sales professional, it took me a while to learn, but you don't go out to Yosemite and have Alex Honnold at the top of Half Dome saying, come on up here. This is where we're going to start.
That's right.
You're like, fuck you. I'm good right where I am. But that's human nature, right? You have to meet people where they are. And then it's baby steps. Like, all right, we have this mapped out. I don't want you to overthink it. We know what we're doing here. This is our plan to educate. This is our plan to get the word out. This is what we see for adoption. This is what you can expect. So maybe just talk a little bit about that, because I think that's a big piece of it, right? We're talking in abstracts right now. What does the implementation look like to an HR team? What does the implementation look like to the boots on the ground, the people, the team?
Well, I know you dealt with that more than I have as far as the implementation side of it.
Yeah. So from our standpoint, right, it's pretty simple. Like we'll customize all the material that goes out for the benefits. We'll communicate in the way that makes the most amount of sense for the employees and for the members of the health plan, right? So whether that's email, whether that's sending direct mail to the house, whether that's putting information into their benefits booklet, whether that's creating a benefits site, like a microsite that goes into their benefits site, we'll do all of those different things, because at the end of the day, people can't utilize a benefit that they don't know is there, right? And that happens all the time. I'm sure you see that all the time, right? There's benefits there, whether they're voluntary or part of health benefits, that nobody has any clue exist.
Exactly.
Right?
You could, open enrollment comes around once a year, get in front of employees, tell them about all these great benefits that they have. and it goes in one ear and out the other. Because at the end of the day, people care about what's my copay going to be?
Right.
What's my deductible? It's all they ever care about. Can I see my doctor? Is my OBGYN in network? Want to make sure that's important. The hospital I care about in network, that's important. If you get that much attention, you're gold.
Right.
But when it comes to all of the other benefits that they have access to, it goes in one ear and out the other.
To be off cycle. If we can be off cycle, that way they're not distracted by anything but just us.
Yeah.
And that way we can really get their attention.
It's always my preference to roll out new benefits off cycle because for exactly that reason, you get their full and undivided attention.
Yeah.
But the great thing about your solution is for people that are managing diabetes, it's not optional for them. It's a way of life.
Right. Exactly.
Right. And if you guys can make their lives easier by getting them what they need and putting them on the path to better management, you're doing good in the world. You're helping them from a savings perspective. And on the flip, you're helping their longevity. You're helping them live longer and hopefully happier life. Because I know I've got family members that suffer with diabetes, and if your sugar is out of whack and you're up and down, it doesn't make for a good time, you know?
Well, having certified diabetes care education specialists and our health advisors, the psychosocial aspect is so huge. And everybody is dealing with that whole process on their own. We do meet them where they are, but it's also on the psychosocial side where are they at? Are they overwhelmed? Are they depressed? Are they angry? Being 20 years in home health care, I had more than one time a nurse come in or a physical therapist come in. Oh, Mrs. Smith is going to have an amputation or is going blind because she's non-compliant or non-adherent. And that's language we don't use, right? Mrs. Smith didn't want to go blind, did she? Or she didn't want to have to lose her lower leg. What's behind that? And I think working with the Behavioral Diabetes Institute, Bill Plonsky, all that has been key to being not just, we were, of course, offer supplies, but I think our bigger thing is we have a behavioral understanding of what's going on and we address that. And that can be key as well.
Awesome. So tell us, how do folks find you guys if they want you out there? They say we have benefits advisors or we have HR tuning in or CFOs. I like the idea of saving a ton of money and doing something good for my people. What's the best way to connect with you guys?
Well, we're online, of course. We have a website. I'm on LinkedIn, David Flakus.
Flakus. All right.
And then I'm based out of Florida, but I cover the eastern part of the country. But of course, we're nationwide. And then Tuck's our COO, and you can reach out. You can find him on LinkedIn too.
Yeah, if you Google me, though, it's a little tricky. I'm like on page 7 once you get through all the other Chris Tucker references.
A lot of Chris Tuckers out there.
Better to go with David anyways. Yeah. So
Right on.
Happy to help you out. However you want to find me. But yeah, we're online, and then also on LinkedIn is probably a couple of the best ways.
Right. Anything else you want to talk about?
Anything else that you would want to talk about, right?
We're talking about GLP-1s or no?
We can talk about GLP-1s if that's of interest to you.
Well, it is because so yesterday I was telling Dave, I got an alert on my phone that the New York Wall Street Journal published an article, and I didn't read the article, but it was something to the effect of a 12-year-old's experience with GLP-1.
Yeah.
And I was like, what the fuck is going on here? Like, what is that? So,
GLP-1.
yeah, tell me, what do you think about this craze? And the other thing is, I just heard that the Biden administration is now trying to get Medicare and Medicaid to offer GLP-1s to Medicare and Medicaid recipients. And I look at that and I have to chuckle. I chuckle for two reasons. So, one, I chuckle because I know that there is fear in the hearts of pharmaceuticals, PBMs, and carriers because of the turnover that's coming in DC. And I don't know if anyone else has a brain in their head, and I'm claiming only to have half a brain in my head. But if you see a story like that, what a smoking gun for let's get this in while we can.
Oh, yeah.
Right? It's just like, thank you, Captain Obvious. You're really going to put this on the American people. So again, not being political, but why would any administration support more spending when we're underwater in terms of our national deficit? You can't, you can only give what you have, and our well is beyond dry. Why would you go down this road? And I'm sure that the counter is going to be, well, we'll save people and we'll spare people because they'll have weight loss. There'll be reduced hospital admissions and surgeries, et cetera, et cetera. And I suppose maybe you can make a case for that. I don't know what the science proves out, but it just seems to me to be a real.
We talked earlier, and coming from the Medicare home care world prior to this world, it kind of blows my mind because you just spoke to the fact that the well's dry right now. Like when you're going to layer in GLP-1s, which is the biggest spend right now for most plans going, it's unfathomable to me. It's very frustrating because there's a lot of providers out there that are struggling to get paid from Medicare now.
Yeah.
And they're adding in a lot of hoops to jump through to get paid. And I just think the GLP-1s are just going to add an unbelievable layer to all that. So.
Yeah, so I want your opinion, but what do you think about, should we really, is there a moral issue in prescribing a GLP-1 to an obese child, or should there be other considerations maybe before going to an RX drug? Or look, maybe to play devil's advocate, maybe there is a real benefit. And I will kind of preface it by saying that Renzo Lozati, the CEO of US RX Care that I interviewed, definitely said that there is merit for patients in taking GLP-1. So it shouldn't be like completely villainized, but should it be used as a weight loss drug versus managing the care of a diabetic? And I'm sure you talk this stuff all day long, so I'd love to hear what you have to say, Chris.
Yeah, so I think there's two different things, and just for maybe the casual listener. So a GLP-1 for a lot of folks is a specific classification of drug that is like an Ozempic, a Trulicity, Rybelsus, Mounjaro, Zepbound. Those are like the common names that you would hear like on commercials for these things. Originally developed for people living with diabetes. They do it. There's a very distinct use case that's scientifically backed for the controlling blood sugar using a GLP-1s. And so there's a place in the world for them for sure, I believe. And just from what I've read from a clinical perspective, the side effect is really the weight loss, right? When you really drill down to it. And then it became obviously popularized because it's a little bit of an easy button from a weight loss perspective. I think the trick from a GLP-1 perspective is, one, you have to really be under clinical supervision, and you really should only be prescribed it by somebody who really knows what's going on and is very up to date on the latest and greatest when it comes to GLP-1s. And that has to do with how much of the drug to take, how do you titrate onto the drug? So essentially, how do you scale up, right? Because these aren't drugs that are designed as just like a single dose, and just take the exact same dose for the life of
set it and forget it.
Set it and forget it. Exactly. They're designed to scale up to a level that your body can tolerate and is going to be the most effective for you.
Yeah.
And then to stay there. They're also, to be clear, were approved by the FDA as forever drugs. Like, they're not, technically speaking, a drug that you're supposed to come on and go off of, right? There is evidence that you can come off of that drug if you titrate off of the drug and then maintain your weight through lifestyle changes, for sure. But just to be, from a technical perspective, in the way that they were approved by the FDA, they are a forever drug, right? So back to your original question, putting a child on them, I don't know. That, to me, that's just not, especially for the purpose of weight loss.
Right.
It's just, I feel like as a society, that's a bridge too far, right? Because essentially, how do you tell a 12-year-old that, hey, we're going to put you on this drug, and technically you're not supposed to come off this drug ever?
Right.
Right?
Right.
I mean,
yeah.
And one of the tricks with these drugs is there's a 50% abandonment rate on the drugs right now, because
that's interesting.
Right. So if you think about it, so if you're prescribed this drug, let's say you're on it for 3 months, right? And eventually you get to a point where you can't tolerate it, or you're not good about taking it. Because it's also one of these drugs that's set up to be very regimented. For the majority, once a week.
Yeah.
Right. 4 doses a month. Once a week on the same day. So like every Monday at 10 a.m. you're taking the drug, right? Because it's a time release thing. So the long and short of it is that you have to really know what you're getting into when you take that drug. And most prescribers out there, and again, not to their fault necessarily, are not up on the latest and greatest when it comes to this, right?
Right.
And there's a lot of misinformation out there. Because it was popularized by a lot of social influencers and social media folks that are, lost, I don't know, tons of weight and,
Sure.
All that kind of stuff. And so, it's a little dangerous right now in kind of the U.S. economy, to be sure. On the Medicaid side of the house, it's interesting to play a little bit of devil's advocate. One argument could be doing that because they can negotiate drug prices without a PBM now, is that if they add that into the thing that they want to offer, potentially they could lower the price for everybody. It's possible.
Okay.
I'm not saying that's going to be the outcome here,
Right.
but that is a potential, right? And so one of the big problems with these drugs is they're super expensive. They're bankrupting health plans.
Right.
They are. If you look at the criteria from a BMI perspective, 50% of a population could qualify for this drug.
Right.
At $1,000 a month, you're going to crush the plan.
Sure.
Right?
Sure.
So the trick is, how do you really find the folks that are going to get the most benefits? So how do you create a funnel, right? You're not looking for the individual that's looking at being on this drug for 3 months to lose weight for their daughter's wedding.
Right.
Like, that's not the use case, right? Like, that's a $3,000 investment that the plan is making in somebody that is going to get zero long-term benefit.
Right.
Right? Zero. So you've got to create.
But I got to fit into the dress.
I know, right?
I have to fit into
That
the
is
dress.
probably definitely going on right now.
It's 100% going on right now. Like, we know it is from our clients, right? And so, and the way that our U.S. healthcare bureaucracy is set up is that the only option plans have is to say no GLP-1s or yes GLP-1s for a weight loss perspective, right? That's it. Those are the only options right now that exist because of the way that the PBMs work, because of the way that rebates work, because of the way the manufacturers do the drugs. They can't go, if you decide you're going to say, hey, GLP-1s are only approved for this class of person, essentially saying this individual that meets these clinical criteria, right? You'll lose your rebate. That's just the way it works right now.
Right.
So then all of a sudden the plan goes, well, if I can't do that, means everybody can take it, which means I'm subject to the person who wants to lose weight for their son or daughter's wedding.
Yeah.
And I don't then premiums are going to go up for everybody on the plan
Right.
by 20% because I've just crushed the numbers of these GLP-1s.
Yep.
So then the only answer they have is not cover it for anyone.
Right.
So then the folk that could really use it,
Right.
that's-
And benefit.
and benefit from it, who's tried everything to lose weight,
Yeah.
but can't seem to do it, is significantly overweight, right? Has comorbid complications from that obesity.
Yeah.
They can no longer benefit from the drug
Yeah.
because essentially it's like it was spoiled for everyone,
Yeah.
right? That kind of
Yeah.
old adage. So the GLP-1 program we created was outside of all of that, right? And created that funnel where you see our prescriber, they run you through a set of clinical guidelines. You get our blood test. You have to control the supply chain, to your point, soup to nuts
Yep.
on this one in order to make sure you only, gatekeep for the people that could really get the most benefit from it.
Yep.
And then they're on it, and then you help them stay on it because they're under clinical supervision the entire time they're on it,
Yeah.
right? So that's kind of what I think is the best.
What do you think the percentage is of people who legitimately need to be on the drug versus those that want to fit into their wedding dress?
Yeah, I mean, I think this is probably a controversial statistic, but from the numbers that I've seen, it's probably 10 to 15% of the U.S. population is going to get the most out of the drug, right? You're going to get that next cohort down that'll get some benefit out of it, but probably not on an ROI basis, right? Based on the expense of these drugs right now, if you're 40 pounds overweight, I don't know. I think the jury's out, right?
Yeah.
If you're 150 pounds overweight, for sure.
Yeah.
Right? I think that there's an opportunity for you to not only get significant health benefits, but from a cost perspective, to save the plan money over time.
Yeah. I feel like we've lost our way. Honestly, I feel like we're at a place now where we almost need a tough dad or a tough Midwestern mom or an Asian mom to just be like, no, you can't have it, son. You can't have it, daughter. We can't afford it, or we don't know enough about it, or it's going to come at too great a cost. And I just feel like we're suffering from the, hey, everybody on the team gets a trophy kind of syndrome. And we got to get tougher. I'm all for helping folks who need a helping hand, but you can't get water from a well.
To your point, I hope
can't.
this 12-year-old, before they jump to the GLP-1s,
Yeah.
there was other things first, like, hey, let's get outside and be active, or let's change. Why? Hopefully, GLP-1s was the last resort rather than
Absolutely.
Yeah.
right away. Let's go for the GLP. Like you said, there is some need for it. I think it is effective, and we should use it as last resort, because it is going to be.
I think that's
forever.
that's the right way to say it, at last resort, right?
Yeah.
I really do believe traditional diet, exercise, is the starting place
Right.
for folks, for sure, right? I mean, it should be
Right.
to change your eating habits, change your
Yeah.
activity habits, like see if you can turn it around that way. To your point, GLP-1s are not side effect free.
Right.
Yeah.
There's definitely side
like,
effects.
Like they're not, right? And it's this idea that it's an easy button, I think is problem with the US culture in general.
Sure.
Right. And I think that it's gotten that rap of like, oh, you just take this injection once a week and you're good to go, eat whatever you want and get skinny.
Right.
Like there are some people that have had that experience, but like who knows what that's going to look like in 5 years?
Right.
Or who knows in 6 years? Who knows? Right. So,
And I think that's the problem. People don't think about the consequences because the universe, it's a give and take.
Right.
There's no
Right.
such thing as get it. You get it all over here, and you also get to have it all over here. It never, ever, ever works out that
Right.
way. It's you want this, you have to sacrifice that. You want that, you have to sacrifice this. It's just a law of the universe. And so when I look at stuff like this, I just hope that people are getting the proper guidance and they're doing their own diligence and their own research and they're being informed because to your point, if all of the literature and all the studies say, hey, this isn't a fad diet, when you go on one of these drugs, you're a lifer.
yeah.
You got to think about that. You really have to think about that. And what are the consequences down the road? And look, let's face it, you guys are in the business. One of the hardest things that you can do is change behavior. Right. So Drucker is famous for saying like culture eats strategy for breakfast.
Yeah.
And I laugh and I say, well, yeah, I could see where he's coming from with that. But without strategy, you don't have a fucking culture. So there's that side of it too. But at the end of the day, I think that people just have to do their research diligence, make their own choices, and it's it. But it's a pricey drug, and there's definitely a cost to be paid, whether it's a monetary cost or whether it's a physical cost. There's definitely a price to be paid.
Yeah. And I think just going into it eyes wide open, right? They're definitely, if you're on the fully insured side, like you're bearing the cost of some of this stuff, depending on your plan, right? Like you're going to see it in your premium increase next year. Premium increases on a year-over-year basis. I've talked to some people that their premium increase was 35% this year, right?
That's insane.
It's insane. How do you do that? What are you, on a year-over-year basis? Like you're going to hit, north of 20% on a premium increase basis. Like, so to your point, like you got to know how the system works.
Yeah.
And you got to know how the game is played in order to not just be subject to every year I'm going to just pay 20% more for healthcare. Right. And get less healthcare, my deductibles are going to go up, my premium is still going to go up. And so if you're a CFO of a plan, you really got to know your numbers. And it's really time to take control of them. And I think you really got to. The other thing I think that it's super important is just getting your data. Like work with advisors that understand the importance of the data and can get it for you. Like if you keep hearing, it's not available, like probably time to switch advisors, in my view, right? Because like the data's out there. And it's just about making those decisions. And so you can make a decision on a diabetes solution. You can make a decision on GLP-1s if you have the information to make the decision. But right now, I feel like the majority of people making decisions for these plans are just throwing darts into the dark. Right? Because you got to know the data.
100%. And that's where the Consolidated Appropriations Act comes in. The data is yours, folks, right? So if you're listening, if you're watching, your data is your own. The health insurance carriers don't like it, but it's really the law of the land right now. And you have access, you're owed access to your pharmacy data and to your claims data. And data is king. And when you are working with advisors that are naming you as their fiduciary so that they're acting in your best interest, you can find out where all the bodies are buried, right? And that's really where the title shift puts you in control instead of being subject to the whims of your health insurance carrier and your benefits broker who's the sales arm of your insurance carrier. But it takes fortitude, it takes courage, and you have to be willing to change. And I always say, like, inspect what you expect. Even my clients, I'll tell them, look, if you think that you can do better somewhere or you want to entertain a call from another broker, I encourage you to do it. Go ahead. Because I know what I do and I know what I share with them. And it's not to say that, we'll save our clients on average 30 to 60%, which is huge, but it's still not enough for many organizations. It boggles the mind, but it's not enough for them to break away from their incumbent broker. And what I would say to that, though, is pay attention to what's going on out there, because with the passage of the CAA, you are a fiduciary and you are operating your plan assets as a fiduciary for your organization and your people, and the lawsuits are coming. They're already here.
Yeah, I know.
So,
Chris Deacon was posting another one the other day.
Yeah.
Yeah.
It's a big deal. And so at the very least, typically your healthcare expense is typically your number one operating expense after payroll. If not, it's close behind. And so why wouldn't you want to take a look at something like this? The beauty of what you guys do, though, is I'm talking about the struggle of an advisor. And we've gotten out of the game of saying, hey, we want to be your broker. We don't want to be anybody's broker. We want to consult.
Yeah.
And at the end of the day, if they'd like to name us as their broker, that's fine. But we'd rather pay them for a service so that we can show them where the bodies are buried, show them the good, bad, and the ugly, and then have them make their own decision. The beauty of what you guys do, though, is you're agnostic. You're really not about replacing a broker or having a client do this or do that. You're simply saying, install our solution. It's turnkey. It's plug and play. And when you do, good things will happen.
Yeah. And I think the other thing is, like, if you have, so we have competitors out there that are really embedded with the carriers, to your point, which I equate to when you're at a car dealership and they tell you to buy the ceramic coating for the undercoating, and then they sell you up on the leather cleaning service, right? Like, it's a great deal. It's not. You're so overpaying for that stuff. It's not even funny. And all of those services are set up as really PMPMs, so they're set up on a per member per month basis. So you're paying for it whether you use it or not.
Right.
And then if you look at the utilization data, you're not using it.
Right.
So I think that's the other way to think about it. So if your carrier's like, oh, don't worry, I got this great diabetes solution that's in there, it's how many people use it?
That's the question.
Am I paying for it whether I use it or not?
Right.
Like, those are really the questions to ask versus just being like, okay, I guess I'm covered, box checked.
Check the box.
Right.
Yeah.
It's like, yeah, if you're checking that box, you're paying probably 150% of what you should be paying for that same service. So those are the other things, to your point, in terms of how you shop for it.
Yeah. All right, guys. I think we're going to leave it there.
Awesome.
Sounds good.
Appreciate you coming out, and go and find these guys. They're out there. LinkedIn, the website, diathrive.com.
I should probably give my email, dflakus@Diathrive. That's probably important too.
dflakus@diathrive.com. You can find these guys.
That's right.
They're
We're around.
accessible. They're good guys. Check them out. Do your diligence. And until next time, folks, peace and love. Peace and love. We'll see you on the next one.
So that's it for today's episode of Broken Healthcare. Head on over to iTunes or wherever you listen and subscribe to the show, and join us on the next episode.